Hello, everybody. Welcome to Classroom. This is an ISNAC initiative. Very happy morning here in India. And today we are going to discuss about status epilepticus and how do we manage status epilepticus. With us today, I have the pleasure of inviting our lead faculty, Professor Gretchen Brophy. She is the Professor of Pharmacotherapy, Outcome Science and Neurosurgery, Virginia Commonwealth University, and she is also the immediate past president of Neurocritical Care Society. It's a great pleasure to welcome you, Dr. Brophy, to our show, and thanks for joining us.
Well, thank you very much for the invitation. This is a wonderful thing that you're doing to help educate others.
Thank you so much. And with us on board is also Dr. Deepti. Hello, Dr. Deepti. Thanks for joining us. Dr. Ajay, Dr. Dheeraj, Dr. Manish, and Dr. Prasanna. So today's topic is a very, very common topic. Status anytime, seizure anytime has to be stopped at whatever cost it is. If we don't stop the seizures, allow it to progress, allow the status epilepticus to happen, and we delay in initiating the treatment, then the outcomes are poor. So such an important topic it is, and such a common scenario it is. And I'll start the case discussion by sharing my screen and presenting the case scenario. So I think you'll be able to see my screen.
Yeah.
Okay. So this is the case scenario. A young male of 24-year-old with no medical comorbidities. He woke up in the morning, he was brushing his teeth and said his mother that he was slightly feeling giddy. And suddenly the mother noticed that his eyes are uprolling, he has jerky movements, look like a fits. The movement stopped, however, he was not responding after that. She called an ambulance. The ambulance paramedics checked his blood sugar, it was 165. And on the way to the hospital, he was seizing again. Now I'll come to the panel to discuss about this scenario on how they manage this case. I'll go directly to Dr. Brophy. Dr. Brophy, this patient had apparently a seizure at home. He had no comorbidities before. But this time when he was going to the hospital in the ambulance, he was seizing again. And he's handled only by the paramedics who may not be very skilled in handling airway. They may not be skilled enough to intubate the airway. Is it advisable to give a benzodiazepine in this scenario to stop a seizure? Because always they are worried about giving benzodiazepine. And this case also, the paramedic was worried about a respiratory depression, which a benzodiazepine can cause. And he just gave 1 milligram of lorazepam instead of the usual dose for a 60 kg patient. So your take on that?
Yes. As you may or may not know, with status epilepticus, again, it's a seizure lasting more than 5 minutes or not recovering between seizures. And no matter what type of seizure you're having, if it's status or if it's just an isolated seizure, you need to stop the seizure. So giving a benzodiazepine is the first line. And with that, lorazepam has proven to be the first line drug of the benzodiazepines for use if you have that available. The respiratory depression is something that should probably be a secondary concern in these patients, because stopping the seizure is more effective at decreasing respiratory depression than the benzodiazepine causing respiratory depression. So it's important to give the appropriate dose to stop the seizures. and not worry about the respiratory depression in that situation. Granted, the emergency technicians that are out, the EMS crew that is out there bringing the patient to the hospital, they do have, that worry, can they intubate the patient, or, if they can't intubate the patient on the way, is that something that's very concerning to them? And I just I'm going to share my screen with you as well, just for a moment, to show you a slide looking at this in regards to the respiratory depression that can occur. And this study, if you can see, is from Dave Tryman back in 1998. So this is 20 years ago. This was our initial study looking at lorazepam and identifying it as the drug of choice for stopping a seizure or status as the first drug. And you can see, and we know that lorazepam was more effective than any of our other anti-epileptic drugs that were tried, the phenobarb, the phenytoin, or the phenytoin plus diazepam. But if you notice here, what I have in the red boxes, the doses that were given are 0.1 milligram per kilogram. The infusion, length of infusion in the study was 4.7 milligrams per minute minutes. And so if you take that times that dosing rate, you see that that's almost a 9 milligram dose of lorazepam. And with that, you can see in the table listed there, the hypoventilation was very similar between lorazepam and the other agents given. So I think the importance of what I'm suggesting here is give the right dose so that you get the effect from the drug, the benzodiazepine, that first agent, to try to stop the seizures. And your risk of respiratory depression is going to be minimal if you follow the guidelines. And in what we have for the guidelines currently is usually a dose no more than 4 milligrams at one time for the lorazepam. So with that, you're way below what was used in that study, and the incidence of respiratory depression hopefully will be minimal.
That's the key. Giving lorazepam at the right time, at the right dose is the key. And we need not worry about respiratory depression, because the most important concern than the respiratory depression is stopping the seizures, because seizures itself has major morbidities and it can produce mortality if it's not arrested properly. And having said that, Dr. Brophy, I just want to ask you another question as well. What benzodiazepine in a preclinical scenario? Because in every guidelines, there is an option, lorazepam versus diazepam versus midazolam. Although lorazepam is preferred because of storage issues or because of the availability issues, they may not have lorazepam at that particular point of time. So if at all we have to use diazepam, or sometimes the IV line may not be available, we not have an IV cannula readily available. So in that scenario, what we do? How do you use midazolam? How do we use diazepam, for example?
Sure. Yeah, there were some great study, a great study done several years ago. I'm going to share you my screen again, looking at different agents. Well, over time, I should tell you, history-wise, we actually started using diazepam as our first-line agent years ago. The reason we stopped using that was, again, if you look at the clinical kinetics of the benzodiazepines, you can see here on this table, lorazepam versus diazepam versus midazolam. The three drugs are different, even though they're in the same class when you look at the kinetics. With lorazepam, and if you look at lipophilicity, meaning the higher the lipophilicity, the more readily it's going to cross the blood-brain barrier and be effective. However, when you look here and you see the high lipophilicity for diazepam and midazolam, those are good agents. They will get to the brain quickly and stop the seizures. However, they redistribute out of the brain very quickly and therefore don't give you a lot of time to control the seizures. The lipophilicity of lorazepam is a little bit lower, so it takes a little more time, usually 2 to 3 minutes versus maybe 1 to 3 minutes to penetrate the CNS. But it stays there for 8 to 12 hours. It gives an effect in the brain for 8 to 12 hours. So as you can see the kinetic profile here with the intracerebral half-life of 12 hours for lorazepam versus 15 to 30 minutes for diazepam, that's why, again, we chose the lorazepam. But again, diazepam and midazolam do work. And in the guidelines, we do have those listed. And if you don't have IV access, you can give midazolam intramuscularly and see the same effect that you're going to get with lorazepam. So the doses that they found in the Rampart study, they used 0.2 milligrams per kilogram up to 10 milligrams as the maximum dose. And that dose can be used out of hospital or in patients where, again, you don't have IV access. And by giving the 10 milligram dose in anyone over 40 kilos in weight, can be just as effective as lorazepam. But again, and because it's intramuscular, you're not seeing, it's a slow depot release. And so you're not seeing the quick effects, like the wearing off of the effects very readily, like you would if you have it IV, where you need to have a continuous infusion. So the midazolam intramuscular is another option if you don't have IV access and you don't have lorazepam available. I know in some countries midazolam is the drug of choice. In that situation, however, the midazolam isn't going to allow very much time, and you really need to start a continuous infusion. And at that point, you would need to intubate the patient. So you've sort of moved along the scenario at that point. And then diazepam as that last option, is usually for the lay persons, with the rectal gels that we have available. But it will work again IV if you use it. But again, the benefits of lorazepam, I think, outweigh the benefits of the other agents in regards to the kinetics of the drug. But midazolam is equivalent to the lorazepam 4 milligrams.
Yeah, that's neatly summarized on what are the options we have got apart from lorazepam and why lorazepam is the recommended agent to choose in this scenario. However, Dr. Brophy, I have to ask you another question as well. So most of the times, these patients, when they reach the Indian hospitals, it's almost more than 30 minutes or maybe an hour or maybe 2 hours or so. So a lot of time has been passed already. So when these patients comes to our emergency room, is it advisable to go with the second line agent and see if the seizure stops, or directly you secure the airway, because by half an hour the airway has to be, it might be compromised. So while securing the airway, we also administer propofol or thiopental to secure the airway along with the muscle relaxant. But once muscle relaxant is given, we will not know the clinical seizures. We will not recognize the clinical seizures. The only way to recognize the clinical seizure is by EEG. So directly now in this scenario, we are jumping from a second line agent to directly to a third line, the anesthetic infusion, and then we are adding a second line agent. So this is a very common scenario. So what is your take on that?
No, that is absolutely acceptable. The number one goal of what we're trying to do in patients with status epilepticus is to stop the seizure. So if the patient has taken 2 hours to get to the hospital, you know that patient has probably been seizing potentially in and out all that entire time. The longer the patient is seizing, the less likely your benzodiazepines are going to work, okay, because your GABA, your postsynaptic GABA receptors internalize, and they're not going to be available when you give your benzodiazepine to have effect. So you have a lot of excitatory and a little bit of inhibitory, and your inhibitory GABA receptors are not available. So at that point, I would absolutely move to the anesthesia and put them, get them into a place where you hopefully can get the EEG going, the continuous EEG, and see where they are and see if they're in non-convulsive status at that point, because obviously the physical symptoms will be gone by that time if they have been continuously in status. So I think it's very acceptable to go to that anesthetic agent, but you're also obviously going to need to load them with those anticonvulsant agents and making sure, again, you're dosing them appropriately based on their weight and getting them on board so that when it's time then to get the EEG going, seeing where they are, you can eventually come off of that anesthetic agent and hopefully still have the seizures controlled. But the order in which we do things again, great example. If your time is that long, you know, do what you have to do to stop the seizure. That's the #1 goal. And then work on the maintenance.
So, so depending upon the time of presentation, we have to adjust our treatment modalities. And the key is that we have to stop the seizures, the status as quickly as possible. And Dr. Brophy, regarding the second line agent, the anticonvulsants, here again, we have got a lot of options to choose from, whether it is evidence-based or whether it is by an independent practice, independent individualized departmental practice. We have got phenytoin, we have got fosphenytoin, we have got valproate, we have levetiracetam, lacosamide is getting added, and a lot of other drugs. Phenobarbital was there before. So always there is a dilemma. Each institute has their own protocol. In India, most of the times phenytoin or fosphenytoin is popular, and sometimes it's underdosed as well. And some people like valproate, and again, the recommended dose for valproate is 40 milligrams per kg when used as a second line agent, but sometimes it's underdosed to 20 milligram per kg. Again, levetiracetam, the dose varies from hospital to hospital. Some give a fixed dose of 1 gram, some goes by weight, some give up to 3 grams. So as a pharmacotherapy professor, could you advise us on how to choose an agent in this scenario as a second line agent, whether to choose phenytoin, whether to choose fosphenytoin or the valproate, or where does levetiracetam stand at present today with this regard?
Yeah, that's a very good question. Unfortunately, we haven't had a lot of new studies that have come out in the last couple of years to help guide us. However, there was one study that did come out called the TRENDS study, the TRENDS trial, and it was looking at lacosamide versus fosphenytoin. And they found it was stopped early, so it was actually underpowered, but they saw no difference in the effectiveness of the two agents. So that at least gives us some data for lacosamide. In regards to levetiracetam, valproate, and phenytoin, there is the ESET trial that is still in, has not been yet released. They have completed enrollment, and we hope to have that data sometime in 2019 to again sort of tell us, is there some benefit based on again that second line agent after they fail benzodiazepines? Is there a drug that's going to stand out above the crowd, right? Because right now, everything that we know, there's really been no head-to-head trials until the TRENDS trial has come out, and the ESET, which we're waiting on. And there have been a couple of other studies, you know, looking at valproate and lacosamide as well. And in those, everything looks comparable so far. Looking at the patient and looking at their side effects, side effects of the agents, okay, looking at the comorbidities of the patient, you know, to see if one drug may be more beneficial than the other based on those, you know, the comorbidities of the patient, or even drug interactions. The older agents, as you know, have a lot of drug interactions. Phenytoin is an enzyme inducer. Valproic acid is actually an enzyme inhibitor. And so if you have those on board with other agents, you could also impact their other comorbid states and treatments. So you might need to pick a newer agent that has less effects generally on less drug interactions and are a little cleaner from the pharmacokinetic standpoint, where you don't have to monitor levels. You can give them some standard doses and have effect based on what we know. But again, you know, looking at picking the agent that's best for the patient. Now, the drugs that have the highest level of evidence are valproic acid and phenytoin, or fosphenytoin. So in all reality, those are the two drugs you probably, that I believe we should go with first line in most of our patients, unless there's a contraindication. However, I know that, you know, it's very difficult sometimes to get those on board, and we can give some of the newer agents a little quicker. And again, we're thinking, you know, cleaner profile. Hopefully they're all working the same, but we just don't have the evidence to back it up. But hopefully soon we will. But otherwise, I think it's really, you know, thinking about the patient and picking the right drug for the right person. But dosing, as you said, is key. you have to dose it appropriately. If you're not giving the appropriate dose, which is in the guidelines, which there are 2 guidelines out there, the guidelines that we have, I'm going to just show you very quickly, are the Neurocritical Care Society guidelines from a couple of years ago, and then the American Epilepsy Society, I'm waiting for this to load, that came out in 2016. These are the 2 guidelines that we have currently available for status epilepticus in regards to guidelines. And they both have dosing recommendations, and I will take you to the table that we have put together for the dosing recommendations in this scenario. And again, you can see the level of evidence for each of these agents that do have some data published. Again, you can see the dosages that are needed and some of the side effects or disadvantages of the drugs that we can pick as well. Again, valproate has the highest level of evidence. Levetiracetam, even though everyone likes to use this drug, has very low levels of evidence, and until the ESET trial comes out, we might not know how well it does and if it does better or worse in our patients. And you can see there that, again, the dose is very variable, up to 3 grams. The only difference with the levetiracetam between the 2 guidelines in regards to dosing is we, in the Neurocritical Care Society guidelines, used a fixed dose of, again, 1 to 3 grams as that load, and then 1500 Q12 is what we would use. Whereas in the American Epilepsy Society, they have actually recommended the 60 milligram per kilo dose with a max of 4,500 milligrams per kilo, or milligrams per dose, excuse me, as a single dose. However, their level is a level U for that, and so I just want to point that out, that there's really no evidence to support that, whereas the evidence that you saw for our levetiracetam is 2B and level C evidence that does show that 1 to 3 grams is effective. So I guess overall, when you look at the data that's out there, again, we need to do more studies. We need to look at these agents and really come up with a better idea of if there is one that's more beneficial than the other when you look at the side effects and the drug interactions.
Okay. My next question to you, Dr. Brophy, is if this second line agent is not working, it's not stopping clinical seizures, will adding one more second line agent going to help, or directly we have to go for an anesthetic agent? Dr. Brophy.
Yes, again, I think we would our goal, I go back to our goal every time, right? Our goal is to stop the seizures as quickly as possible. We don't know if adding a second anticonvulsant is going to help us. There's no data to say that that second anticonvulsant agent is going to help us. What we do know is the anesthetic agents work, and they will stop the seizure if we dose them appropriately. So time is brain. So we need to go straight from using that second line agent. If you can intubate the patient, because you're going to have to do that with any of the anesthetics, but intubate the patient, get that anesthetic on board and stop the seizures is the goal, and that would be my recommendation. If there's some reason you cannot intubate the patient, obviously you're going to use those other anticonvulsants based, again, on the patient and the risk benefit for the patient based on the agent. But if you have the opportunity to give an anesthetic agent, that would be the key, stopping the seizures as early as possible.
Yeah, that's very crystal clear message. The goal is to stop the seizures. So whatever agent which is effective, put it before, and we need not wait. We need not worry about the respiratory depression. The patient's airway and breathing can be taken care of. So what I will do now is I'll just go to the other panelists and get them their practice. How do they approach status epilepticus? And then I'll come back again to discuss the various practices which we see across the institute. First, I'll ask Dr. Prasanna about their institutional practice in status epilepticus.
Yeah, thank you, Ponniah. Actually, we are honored to have Brophy today, and most of the things is covered. It is essentially same what we practice in our institute. So the only point what I was trying to add here is, In India, we have a variety of setups where everything may not be available. As far as you have a good setup with the emergency medicine department or ICU or a neurointensive care unit where you can shift the patient directly to there and intubate and start a midazolam infusion, it's fine. But if you have a setup, for example, it's a community disease. So, for example, if the patient comes in a community health center or a rural health center, you don't have the facilities of the ICU or even sometimes intubation. So, addition of a second line drug, one more, I would prefer rather than giving a midazolam and landing up in trouble, not able to ventilate the patient, not able to intubate and causing more hypoxia to the patient. That's the only thing. Otherwise, essentially the practice is same. We start with lorazepam, add phenytoin, and then if we are not able to control, straight away shift the patient to the ICU, intubate, and continue with either midazolam or propofol infusion. Essentially, it is same.
Okay. Dr. Ajay, what is your practice in Trivandrum?
I also agree with Prasanna, sir. Actually, here we use lorazepam followed by phenytoin, and we do use Levipral. We give a standard bolus of 2.5 to 3 grams loading, and especially in patients who are having phenytoin allergy, because we do get patients who are having eptoin allergy. So, in those scenarios, we go ahead with the Levipil loading of levetiracetam loading of 3 grams, and what I would like to add is the most common scenario where we get a status epilepticus in our sitting is because most of these patients will be on phenytoin, which has a narrow therapeutic window. So what happens is they'll skip one dose, or the sister will delay the dosing in the ward, and that is when the patient will start seizing. So rather than jumping the gun, what we usually sometimes do is we give a half loading dose of phenytoin, and that settles the story in the first step. And in the meantime, we administer oxygen also so as to maintain the saturation. If any point we are not able to manage the airway or the oxygenation, that is the point we skip into the intubation along with the anesthetic agent. And a couple of things I would like to add is in that case discussion where we go ahead with the anesthesia management part. I would like to add that, especially if the patient is having a seizure for last 1.5 hours, it's better to avoid succinylcholine because most of the centers in India still go ahead with succinylcholine. And these patients will be already having rhabdomyolysis after so much of seizures time. And most centers still go ahead with succinylcholine. So it's better to avoid succinylcholine for the hyperkalemia part. And another thing I would like to add is we commonly use thiopentone or propofol to intubate, and along with sometimes succinylcholine or rocuronium. And we give a maintenance of vecuronium or atracurium. So what happens is after the bolus dose of anesthetic agent, along with the paralyzing agent, then there is no maintenance is happening till for the next 45 minutes to 1 hour till the patient gets connected to a EEG or anything in the ICU. So what I would like to add is we have to immediately start the maintenance dose of the anesthetic agent also, because the patient will be actually seizing, but it will not be a clinical seizure because of the residual paralyzing agent. So, and most of the times they will be in a non-convulsive status phase. So, our center, we go ahead with lorazepam. Second line is phenytoin, levetiracetam. And then third line is propofol and thio.
Okay. Dr. Deepti, what is your practice in All India Institute? Deepti, can you switch on your mic here?
So in the emergency services in our institute, we have the availability of both lorazepam and midazolam. However, it also depends, like a lot of patients who already have epilepsy have a know-how of, giving intranasal midazolam, for example. So that is one thing which is available. So a spray is available. So that is also often used by patients who are under our follow-up and come with a withdrawal seizure. That's one good advancement which is taking place. The other thing is once we have loaded the patient, once we have given the patient lorazepam, it's an important question that how to prevent further seizures. And the most important thing to understand then is what is the etiology of seizures. If the patient is already has an epileptic disorder and we know that there is some lesion in the brain or a mesial temporal sclerosis, and the patient is on some maintenance drug, we need to add or understand that the patient missed the dose or was on inadequate doses. So we send off the drug levels, and then we give the loading dose of the appropriate drug. So if it's a partial seizure, we would take the appropriate drugs or a broad spectrum drug. If the patient is already in hypotension, then we would avoid phenytoin and give valproate or levetiracetam. So it has to be customized according to the patient profile. So that is what we do. Yeah.
Okay. Dr. Dheeraj, quickly. Switch on your mic here. Switch on your mic.
Yeah, can you hear me, sir?
Yeah.
Sir, mine is like almost everyone has covered everything. So what point I would like to tell is usually in the practical scenario in emergency, we cannot divide into first line, second line, all these things. Everything should go together, I feel. It is what I do practically is the moment I go, I feel midazolam has a quicker action than lorazepam. So I give a midazolam 1 or 2 mg to the patient, control the seizure immediately, and parallelly second line also will be started to the hospital. We for 30 mg per kg.
Okay, all right.
1.5 to 2 grams we give. Parallelly, once it comes to neuro-IC, it's a different situation.
Okay, I think Dheeraj, you have some problem with the network. I'll just go to Dr. Brophy. Dr. Brophy, the one most important thing even Dr. Deepti was mentioning is that the etiology. Some of these patients maybe already taking anti-epileptics. They might have skipped the dose, things like that. They might also can come with status epilepticus. So how to approach this subgroup of patients?
And those patients, definitely, I mean, one of the number one reasons, right, that patients come in with status is because they missed their medication. They didn't have the money to pay for their medication, et cetera. And if you know, though, a patient, if you can get the history from the family as they come in or from the patient and find out that they are on an agent that does work for them, absolutely, that is the drug you should go with. Get it back on board, load them up, if you know, and if you can get it level, depending on which agent it is. If you can, the older drugs you can get levels on. But again, getting something on board quickly. And then once you find out the medical history of the patient, get that drug on board that works for them.
Yeah, that's great. Now what I'll do is I'll share my screen to show what happened to this patient which we were discussing.
Just have a small question to Dr. Deepti.
So this patient, when he, I hope you're able to see the screen, when this patient, when he reached the ER, just a second, I'll just share my screen to you. Yeah. So this patient, when he reached the ER, he was, CRV was already compromised. Like I said to you before, this patient received only 1 milligram of dose of lorazepam, and he was in severe acidosis. The respiratory depression was there. Even though the benzodiazepine is not given, people need to understand that status epilepticus itself can cause respiratory depression, and he was in severe acidosis as well. So here, immediately the patient was given oxygen bolus dose of propofol, and the airway was secured after giving muscle relaxant. You see the lactate is 21 millimoles. So propofol infusion was started, and he was shifted to the ICU, and the EEG was initiated. Before the EEG, a CT scan was done, which didn't show any abnormality. So the EEG pattern looked like burst oppression, and this was continued for another 24 hours. So now I will go to Dr. Deepti and ask her if this is the scenario and the patient has been already initiated on burst suppression because of his compromised airway and is metabolically decompensated. He was intubated and the propofol infusion started. Of course, after the propofol infusion was initiated, fosphenytoin was also loaded. But this is the EEG pattern. So how do you go from here? Whether you want to continue this EEG pattern in the burst suppression for another 24 hours, or rather you would reduce the dose of the propofol, come down, and you accept any activity where there are no spikes or no seizure activity. So how do you go about from here on?
Okay, so once we have the CEG on board and we are monitoring the patient clinically as well as via EEG, the next main step is to abort any clinical seizures. And once we have reached the state of burst suppression, then there is no clear-cut guideline as to how many hours are we going to continue that. I have a study which I can share with you, and which is a very nice study. So I'll just do that, which shows that what are the practicing trends of people who use CEG and burst suppression. So I'll share that slide with you. Yeah, here. So as you can see, the uses of EEG monitoring in management of patients with non-convulsive seizures, and they used, so 83% use CEG at least once per month. And how long do we continue if no seizures are detected in a patient who is comatose and has discharges? So it varies anywhere, but most commonly used practices of 24 hours. And if the non-convulsive seizures are also terminated, then the most common practice is to use it for 24 hours. However, you can also see the spectrum that, it might vary from 3 to 6 hours up to 72 hours. So the endpoint to treat is resolution of the epileptiform discharges or burst suppression. But if there are pros and cons of anyway, treating it to burst suppression, because when we increase the vulnerability of the brain to permanent damage by the mechanisms of secondary injury, we are protecting that by the patient being in burst suppression. And we probably also know that, if there are lots of seizures, then the mortality will be higher. However, there are cons for it also. There are problems with maintaining the patient in burst suppression for a long time. Now, aggressive coma-inducing treatment is anyway associated with 50% mortality regardless of the agent utilized. And very few patients die directly of status epilepticus. And a large percentage of these patients also die from ICU complications and infections. So when I would share that, I would again go back to the same thing which we were talking about, that actually at the end of the day, you have to see whether the patient had landed in that status epilepticus because of an underlying multi-organ dysfunction related to sepsis, or was it just a drug withdrawal seizure? So it has to be tailored according to the entire story of the patient.
Okay, thank you so much. So,
yeah.
I will go to Dr. Manish. Dr. Manish, Dr. Deepti brought an important point, saying that sometimes when we treat status epilepticus, when the patient is in refractory status epilepticus, you initiate burst suppression with anesthetic agent. Instead of dying from status epilepticus, some of the patients even die of ICU complications related to the therapy as well. So what is your take on that?
Yeah, this is true. We don't have much evidence to suggest how long should we continue with the induced coma and suppress EEG. Again, the endpoint of our treatment is not very well defined. It is very clear that we need to abort the seizures immediately, and then we have to keep the patient in seizure-free period as much, or aggressively we should keep the patient seizure-free. But regarding EEG, use of EEG in these patients and how much suppression we should achieve in EEG, it is not very clear. So usually what we do suppression of EEG for some time, maybe depending upon the pathology also. Like for EEG cases where the patient skipped antiepileptics, we do not give continuous IV agents for a longer time. But in cases where there is autoimmune encephalitis or other types of encephalitis, or the patients who have prolonged conditions where we anticipate the outcome to not be so good, we keep the patient for longer time under induced coma. So endpoints are not very clear.
So what is your preferred agent in this scenario? It is thiopentone or propofol or midazolam? What is your preferred agent for continuous infusion?
We usually use IV midazolam infusion as a first agent of our choice, but sometimes we also use thiopentane.
So midazolam targeted to what EEG pattern?
It should be spike free, like seizure activity should be suppressed with the IV infusion. It is difficult to achieve many times, so that we have to sometimes start thiopentane instead of midazolam.
So what's the maximum dose of midazolam you have used?
We have used up to 15 milligram per hour, 15-20 milligram per hour.
Okay, so that's not really very high.
It is not very high dose. Yes.
It's not really very high. Okay, so I'll go to Dr. Prasanna and also ask his drug of preference in this scenario.
Yeah, first and foremost, I would go for a midazolam infusion, escalate it, and with a continuous EEG monitoring. I would be happy first to achieve a seizure-free EEG. And then if I see that some encephalitis or something is suspected clinically, I would achieve a burst suppression pattern. May not be isoelectric EEG, but at least the EFNS guideline says at least achieve a burst suppression pattern. And once you go to this high end, I would be rather patient than de-escalating the doses. So at least for a 24 hours period, I would wait. Then step by step, go down very slowly, because I have seen for 7 ml per hour infusion of propofol will not cause a seizure in the patient. You come down to 6 ml, it again starts. So once it starts, again, whole the cycle is repeated. So it becomes very difficult. So rather, I would be more patient, and go very slow, even sometimes up to 0.1, 0.2 ml per hour infusion, reducing, go down very slowly to achieve a seizure-free interval. That is the key, rather than having impatient and start multiple agents then. So if I see that I am not able to achieve this seizure-free interval through midazolam, I would switch over to propofol rather than going to the hapendone sedim, simply because the recovery is very prolonged. I have seen that patients are not woken up for 3 days, 4 days when we start with nearly 20 milligram per kg thiopentone and then continuous infusion. Because of the zero order kinetics, it accumulates and then it will be very difficult. You really don't know whether there is a irreversible damage to the brain, that's why patient is not coming out, or is it the accumulation of the agent because of it. So rather I would prefer a propofol after midazolam than thiopentone. There is no clear guidelines or this one. That's my personal practice, what I would
No,
prefer.
I don't understand. You said midazolam, if doesn't work proper. Midazolam, what is the maximum dose you go till the time you say that it's not working?
And to 20 milligram, to 20 to 25 milligram per hour.
Okay,
So
but the
I'd go.
recommended doses is even much more than that. It's about
Yeah.
2 milligrams per kg per hour.
The problem is, one is the seizures are continuing, second one is the hypotension starts there. So rather I would go switch over to the propofol and assist with a vasopressor. So there is no clear guidelines. By the time you become impatient, maybe that is the reason. So
Okay. Dr.
My
Ajay,
my
what is,
my
Dr. Ajay,
preference to
what is,
my preference to thiopentane is because once the seizures do not respond to midazolam and we need propofol, usually we need it for a longer time, and it is difficult to use propofol for say more than two days. So that
okay.
in these situations, I prefer to use thiopentane first in comparison to propofol.
Okay, Dr. Manish, from both you and Dr. Prasanna, whatever you said, the doses of midazolam, it's about only 15 to 20 milligrams per hour. It's not a very, very high dose. So maybe that could be one of the reasons, because midazolam dose can be escalated even up to 2.4 milligram per kg per hour as per the guidelines.
In our center,
Okay, I'll go to Dr. Ajay. Yeah, Dr. Ajay, what is your drug of choice in this scenario, in refractory
our
status?
center actually, after the imaging and ruling out of any structural abnormality, we then go ahead with anesthesia management. So we start off with midazolam, and in our center we go up to 7 to 8 milligrams per kg per hour. So, but what we notice is initially there will be a seizure control, but they all rapidly develop tachyphylaxis at the same rate.
Hold on. You said 7 to 8 milligram per kg per hour of midazolam?
Yes.
Are you sure?
Yes, we go up to that, and we keep a
No,
non.
it's almost mounting for a 50 kg. It's about 350 milligram per hour.
Yes, we go for that high.
So what preparation you use that? 1 milligram per ml or 5
the first day, we go ahead with what we usually do is we start off with 1 to 2 milligrams per kg per hour, and then it goes up to 5 to 8 milligrams per kg per hour. It is individualized based on the patient, and we also add on noradrenaline to maintain the, to manage the hypertension.
No, what preparation you use midazolam?
We use Versat, the normal.
The 1 milligram per ml preparation.
Yeah, one, and it's quite cumbersome for the ICU sisters because they'll have to keep managing.
No, because by the dose, what you're saying, they might be giving 300 ml per hour.
Yeah, it's sometimes we do have had cases where it has gone like this, and I think there is one more 10 milligram per ml preparation also comes, so that also can be used. And what?
No, wait, 1 second. I'll just quickly go to Dr. Brophy and ask about this very high dose of midazolam, whether this dose really works or the patient has already developed tachyphylaxis, because the maximum recommended dose itself is only 2 to 2.4 milligram per kg per hour. Dr. Brophy,
Yes.
Your comments?
Yes, I think this is a great conversation. I'm going to share my screen with you again because I do have one slide that's just looking exactly at this picture. And it shows you here, when you get to these high doses of midazolam, for this, they looked at 2 different time periods, and they looked at a low dose group and they looked at a high dose group, and this is from 2014. The low dose group, the suggested max was 0.4 milligrams per kilo per hour. And in the high dose, it was 2.9 milligrams per kilo per hour. The high dose group had less withdrawal seizures and lower discharge mortality. And if you look at the median doses that they used, I agree with you that the doses that you were just mentioning are extremely high. So I don't know if you're getting much benefit at that point. But if you're looking at the median doses just in these two groups, the median maximum dose that was used was either 0.2 milligrams per hour or 0.4 milligrams per hour, even in that high dose group. But it ranged, they really didn't even get up past 1 milligram per kilo per hour in these refractory patients. And 50% of the patients in that high dose group actually received less than that 0.4 milligrams per kilo per hour. So now when they treated these patients, they did have a benefit even at these lower doses. So even as you go, 5 times this really, right? So if you get up to 2 milligrams per kilo per hour, as Ponniah was saying, I think those higher doses, we get into a situation where we need to ask ourselves, is the drug really working? Or do we need to switch to another drug that has a different mechanism or works differently at the GABA receptor? Because that tachyphylaxis will occur, and I don't know how the pharmacy, and the nurses at the bedside keep up with your drips. If you're really running them that high, you would have to replace. It would be a lot of cost and a lot of drug and a lot of work to do that. So in that situation, I would say move to a combination of 2 anesthetic agents instead of, using just the one and pushing it that high, because the GABA receptor has 5 different subunits. The benzodiazepines work at one of those subunits. The barbiturates work at a different subunit, and propofol works again at a different subunit. And so if you have to go with that high dose midazolam, once you get up to, I even say, even based on that study you just saw where they did have a lot of benefit, even at 0.4 milligrams per kilo per hour, if you're getting up much past that, I would say try a combination or try another agent at that point, because I think that, you're just not, it's not going to work to the benefit. It may not work, although there is documentation that people have really pushed it high and got effect. And it might have been that it could have been the drug. It could have been the other anticonvulsants that were added on and finally got to steady state. And therefore you're seeing an effect from something else you did earlier. Or, it's a combination of everything, that concentration where it, again, is reaching steady state and they're all working. Because the drugs that we put on are not all stopping it immediately. It takes sometimes hours for it to achieve the goal. Now, even with the midazolam too, I would say if you're going to go up on the drip, and the patient's not controlled, you need to bolus that patient with the midazolam on top of increasing the drip, because if not, it's going to take you a while before that drip again achieves the new steady state in order to get effect. So you need to bolus and increase the dose, bolus and increase the dose. And if you're not getting effect after you do that up to, again, a 0.4, 0.5, or maybe even 1 gram per kilo per hour, then think of a different agent, or get your maintenance medications on board and get them optimized so that you can try to have additive combinations.
I'll go to Dr. Dheeraj. Here's some studies for us to show comparing different agents in this scenario of refractory status epilepticus. Dr. Dheeraj, can you share those studies? I think I lost Dr. Dheeraj. So
can I just add on to?
Yeah, I'll go to Dr. Ajay now. Yeah, Dr. Ajay.
Yeah, I was telling that we have gone up to that. It's not the routine practice. That is what I was telling. So we have gone up to that level. And usually what we do is, after we cross 1 milligram per kg per hour, we add on propofol as the second line.
Exactly, that she was mentioning, yeah.
So we add propofol to it as the second line. And once propofol also we are not able, and we actually target for 50% burst suppression. That is our end point usually we see for, or at least a 30-second seizure-free window. And once we are not able to achieve it with propofol, we either switch over to off late. Last 1 year we are using ketamine infusion and or thiopentone. Usually the 3 infusions will be in parallel, and we maintain it at least for 48 hours before starting to titrate it again, coming down. At the same time, we load the patient with second line drugs and optimize the levels for all that before we come down on the anesthetic agents. So that is how we usually go about. And off late, thiopentone has been mostly replaced by ketamine in our center as the third additional anesthetic.
I'll come to that later. I'll just go to Dr. Brophy. Dr. Brophy, in this scenario, we have midazolam, we have propofol, we have thiopentone, and also phenobarbital. So what agent to use? Is one agent having advantage over other? How to choose an agent?
A very good, again, good points to bring up here, because you have to look at what's happening with your patient. The different drugs that we have for refractory status epilepticus are not benign. They all have their side effects that we have to worry about. And so when you're looking at the different agents, that's key, to the decision you're going to make. Let me show you a slide here with some of the data for these agents. To walk through it a little bit, as we've talked about midazolam, pentobarbital, propofol, and then the thiopental could be put in that category with our pentobarbital. These agents, again, as we get to this point, there are no studies that have said whether one drug is better than the other drug in these situations. So if you look at the columns here, I have on advantages and disadvantages of the 3 agents here. Pentobarb and thiopental probably have the worst side effects of all of these, just because of the immunosuppression, the infections, the ileus that can develop, etc., in these patients. And the hypotension is so incredible, you have to use pressor agents. Now, propofol sort of in that same boat, right? If you have a very hypotensive patient to start with, propofol is only going to lower the blood pressure even more. And so you have to really think about that. And then propofol-related infusion syndrome, especially in the case you just presented, the patient was, because he had been continuously seizing, he was acidotic, right? And so with propofol, if you're going to use that drug and push it to very high doses and use it for long periods of time, you have to worry about propofol-related infusion syndrome, which also can cause rhabdomyolysis, hyperkalemia, cardiac arrest, and death. And so as you're looking at your patient and choosing which agent you would like to use, you have to think of again, what's the worst, what's the best of these 3 drugs, even though they're probably not any of them really good options. So in our situation at our institution, what generally will happen is we do start with propofol a lot of the time, and then we'll move to midazolam, and we will save pentobarbital to the very end, so that, again, because it has the most side effects. And the question that we'll get to, I think, eventually is the ketamine, because again, as these patients continue to seize, it's the excitatory component that we really need to try to suppress, and slow down the metabolic rate of the brain to help preserve the function. So thinking about the pros and cons of each agent is going to be very, very key as you pick that anesthetic agent.
Okay, right. Nicely summarized that. I'll go to Dr. Deepti. Dr. Deepti, sometimes everybody agreed that most of the times they'll be using 24 to 48 hours of their EEG targets, maybe burst suppression, whatever percentage burst and suppression is. But when we are withdrawing the therapy, like Dr. Prasanna mentioned, sometimes we'll be seeing some seizure activity in the EEG, although the patient is not clinically seizing, the non-convulsive status epilepticus. So what are all the EEG patterns which needs aggressive treatment that we have to put the patient again back to coma? And there are some ictal patterns which may not be that harmful when you compare with the risks of the treatment itself. As you rightly said, the ICU complications with the prolonged treatment of these anesthetic infusions is going to have on the patient. So can you just give a brief about the malignant EEG patterns which definitely has to be treated, and some ictal patterns which that we may not treat that aggressively? Yeah.
So I'll show you that, but I really appreciate bringing in ketamine here, because ketamine is also a good drug of choice because of its mechanism of action, and also because it doesn't cause hypotension. So when we are in a particular patient scenario situation, that is one drug that I have also found really, really very useful. So now I'll share the slides for the EEG thing. Just go there. Okay, so here we see a slide which is showing generalized non-convulsive status. The important thing to understand when we are looking at EEGs is to see the evolution. So we see here that there is a generalized status epilepticus in a 75-year-old woman with history of seizures and now confused and lethargic, with the EEG showing high voltage 3 Hz sharp and slow wave discharges with periods of diffuse delta. And once we give IV lorazepam, look at the way the EEG changes, So there is cessation of ictal activity, mild diffuse slowing, and then there's beta activity in the posterior, which anterior beta activity, which comes up. Now, when you're talking about focal non-convulsive status will have discharges which are lateralized or localized. So this we see ictal discharges, sharp and slow waves occurring more on the left hemisphere. And then generalized non-convulsive status in a typical, absence status is something like this, which it looks like, and these are usually found in young patients. Now, to compress the slide and see what exactly a burst suppression would look like after the infusion would be, bursts, absent seizures, and then suppression, then again a flurry of absent seizures. So it's once the evolution of the EEG, and then how does it subside? So atypical absences also, I've shown you this EEG trace just to see that there are epileptic encephalopathies in which even the interictal ED would just go on and on like this. This we need not treat aggressively because we know that the underlying pathology is grave. However, when we are dealing with features like focal non-convulsive status or complex partial non-convulsive status, we need to abolish this pattern. We might still have focal slowing, depending upon whether the patient has herpes encephalitis or an infarct in that area. That is not what we need to chase. We basically need to chase the epileptiform discharges, and whether I will show you another trace in which what is important to understand is that there should be an onset and there should be a build-up. If it is building up like this, and then it's going on to a florid, generalized, sharp and slow wave, that is where the point where we see that the patient is having an electrographic seizure, irrespective of the fact that there are no clinical seizures. Once the clinical seizures have aborted, as well as the EEG pattern is not showing sharp and slow wave discharges, but might be showing still slowing, but not an evolution or electrographic convulsive activity for more than 10 seconds. So a page, that is where you feel that you can go a little slow and taper your antiepileptic infusions, third line infusions, and then go on to the maintenance antiepileptic drug, which you would anyway give the patient once you stop the anesthetic agents.
Thanks, Dr. Deepti. That was nicely summarized. I'll talk to Dr. Brophy. Dr. Brophy, now when we are withdrawing the patient from the anesthetic infusion, I'm sorry. Sometimes we see these activities, and Dr. Deepti has nicely summarized what are the patterns which we need to treat aggressively and some interictal patterns that we need not treat aggressively. So it is at this point of time, most of our clinicians think of adding some agents like ketamine, lacosamide, magnesium sulfate, and the list goes on, where we don't have definitive evidence on which agent will work better or not. So I just want to ask you briefly, where does ketamine stands as of now? Because most of the consultants, even though with lack of evidence, are fond of using ketamine even at the beginning when they initiate anesthetic infusion, and some even at the time of intubation, when they are doing an intubation along with propofol, they give a low dose of ketamine. So where does all these agents stand as of now today? How to use them judiciously?
Right. That's the $1 million question, right? As to when are we going to use ketamine, and when do we know it's going to be effective? Because the studies that are out there, there's some that have shown it to be effective, and others that have shown it has not been effective. The data is very weak with all of our refractory status patients. For the anesthetics we know will work. We don't know which one in which patient. What we are currently doing is we try the anesthetic agent, and we try to wean it after that first 24 hours. And if we can't wean it at that first 24 hours, we will go back onto the anesthetic agent. And usually it's midazolam at that point. And we will then add the ketamine to that to see if we can get the combination to be effective, together. And but the app, and again, it's because of that excitatory phase that we really aren't working. We're not working on the NMDA receptor, which is where ketamine is going to work when we're using the other agents. And so with that, it's probably how we're using it a lot in the institutions here in the US is after we've used that anesthetic, after we've tried to wean it, it doesn't wean, we'll add it back on, or add the ketamine on, and then try to wean down the others depending on how the hemostasis, the hemodynamics are for the patient, because obviously the ketamine will help us where we have the hypotension with the other agents. So everybody's doing it differently. I think until we have a little bit more data, we're not going to know where to use it. There is one study I'll just show you quickly that did sort of address or look at this. This was in 2015. It was the combination for these patients for what we call super refractory status, which again, after you've tried to wean the patient off the anesthetic and you can't, and they go back into status, so you go back up. You can see that they added this, in this case, they had propofol and ketamine together, and they used very high doses, doses of both of these agents just to see if they could get some effect in those patients. And in the 67 patients they tried it in, status was controlled in about 91%. But again, the mortality was almost 40%. So when you're at this phase in in these patients, it's again, we don't have any good answers as to what agent is best for all patients, and how we should be addressing the lineup at this point. So I think looking at the patient, looking at the EEG, getting the feedback on if it looks, if we can figure out if it's more excitatory, if the GABA agonists are not working to the full effect, I think ketamine is definitely a good choice at that point. Ponniah, are you there?
Yeah, your conversation is muted, I think.
Oh, sorry. I'm really sorry for that. So as we are ending the discussion, I just also want to ask Dr. Brophy about these two drugs, namely the lacosamide and perampanel, which are being used of late recently in status epilepticus. So I just want to take on these two drugs, Dr. Brophy.
Again, the data is very, very limited for these, although lacosamide has more data now because, again, the TRENDS trial that just finished did show that the lacosamide at a 400 milligram loading dose compared to the fosphenytoin was non-inferior to the fosphenytoin. So if we had to go by the evidence, which we always try to suggest, use our best evidence to help us treat these patients, lacosamide then would have a lot more information on it than any of our other newer drugs in regards to the type of trials that have been done. So, and it does appear to be as effective as the fosphenytoin. And in regards to perampanel, it has been tried. There's been 2 small studies. And with that perampanel, they did have some effect, but they had to use some of the very high doses, and that's an AMPA receptor agent. And so with that agent, one of the things that has been a problem, even in these small case studies, is they have liver adverse effects in these patients. So just know, again, you have to think about the drugs and the side effects of the agents. And if we're using them for status, we're going to be using them at the very high doses. So we really need some studies to be done on these agents to help guide us so we don't cause more harm to the patient. But right now, I would say lacosamide, out of all of the newer agents, actually has the most data and at least has shown to be as effective as some of the other agents we're currently using.
Okay. Before wrapping up this discussion, I'll get the final remarks from all our panelists, and then we'll wrap up this discussion. Dr. Prasanna?
Yeah, actually, I just wanted to ask a panelist all, including Brophy, the question. One is, are we abusing levetiracetam just because it has a better safety profile? We want to use it everywhere when the data is not available. The second one is in status epilepticus, once it becomes refractory, super refractory, you try up all the agents, then also nothing happens. So finally, do you give up? Till how long you continue the treatment? So there are so many times, though the incidence is very less, maybe 2 to 5% of the patients where we'll not be able to treat it at any cost. So do you accept the prognosis and give it up, or you continue to try? If try, then how long?
Okay, I'll go to Dr. Brophy last with this question. Let Manish give his final remarks. Yeah, Manish.
Yeah. Again, I also wanted to ask a few questions to panelists if the time permits. Sometimes it happens that when we treat the patient for status epilepticus, the clinical seizures go away, but sometimes there are still discharges on EEG. Secondly, sometimes the seizure become partial. The patient may regain the consciousness and still there can be some partial convulsive activity going on. So how to treat in these situations?
Okay. Dr. Deepti, you can give your final remarks and answer Dr. Manish's question as well.
Yeah, so we are talking about the Indian scenario. I would like to share a study which we published in Seizure, I think 2010, 8 years back. So I'll just share that one slide with you because when I was going through the discussion, I found it useful. So we get a lot of patients of refractory status epilepticus, and we don't have ICU beds, we don't have ventilators. So we did this trial in a small number of patients, and we subjected them, we randomized them to 2 medications. One was, group A was valproate and group B was levetiracetam. And this was headed by Dr. Manjari, this study. So we found that we could still have the patients off status in around 70%, and only 30% approximately in each group required intubation. And we could reduce the ICU days, and the mortality was the same. So when it comes to practical scenarios, we have these questions and we try to generate answers in our own way. So the advantage with valproate and levetiracetam in our setting is that they don't cause hypotension. Ultimately, they have to be on antiepileptic drugs. And when it comes to what are the chances that they will be off status is pretty good, promising, because the most common cause of status is eventually, a seizure, drug withdrawal, or simpler reasons. And there would be always a 30 to 40% group who would have, grave diseases like multi-organ dysfunction, like autoimmune encephalitis, like uremia with sepsis, with 10 other things happening in the background in an 80-year-old person. So we have to customize it, tailor-made for each patient. So that is how we do it in practical situation.
Okay. Thank you, Dr. Deepti. Dr. Ajay, your final remarks?
I have just a couple of queries to Dr. Brophy. Here we do encounter a lot of super refractory seizures in our center. So I just want her take on isoflurane, which we have found successful in a couple of patients, and also her take on hypothermia, whether she has had any encounters with hypothermia in this setting, and also with isoflurane in this kind of setting. How does it?
Okay. Dr. Dheeraj, I'm sorry I lost you in between. Are you there? Okay, there is some problem with Dr. Dheeraj. Yeah. Dr. Brophy, your final remarks and answers to some of the questions which has been raised about inhalation agents. Where does inhalation agent stands in the refractory status or super refractory status, and other things like hypothermia, even surgeries in this case for setup. Or Dr. Prasanna mentioned that should we give up at some point of time instead of keep on adding agents and drugs, that it might work. And he was also raising a valid question of are we overusing levetiracetam without much evidence? Dr. Brophy.
Well, do we have, if we had 4 more hours, I could answer all of those questions. However, in a brief snippet, what I would say is that, again, the data that we have, we need more research. We need more research in status epilepticus in order to help us make these decisions. The drugs, the newer agents that we have out, we are just now testing against some of our older agents, even though majority of us are using levetiracetam all the time. It does affect the synaptical vesicle 2A, which it's inhibiting the release of glutamate, so trying to stop it there. But levetiracetam also affects the AMPA receptor. And so in some of our patients, if they have underlying neurological injury or stroke, and they're having seizures, they actually have a very bad behavioral side effects with the frustration and the irritability and just major behavioral changes, maybe due to that AMPA, the AMPA receptor effects of the levetiracetam. There is a newer agent out, brivaracetam, that may not be available in every country yet, but it only works at the SV2A receptor. So maybe we'll see less side effects, but we don't know yet because it's not been out that long. But levetiracetam appears to be effective. Once the ESET study comes out, we'll know more and we'll have some good data to back us up. Again, it's easy to use and less side effects. In regards to refractory, super refractory status epilepticus, I am going to share my slide or my screen with you one more time, just to show you a slide of what we had done for treatment of super refractory status and what we'd recommended in an article a couple years back. And there are other agents that we can go with. As you mentioned, the hypothermia, as well as inhaled anesthetics. And you can see after you get to super refractory, you have a bunch of different agents that you can use here, including those agents and hypothermia, as well as IV steroids or IVIG if we have autoimmune issue, induced status. Also, you can see with the adjunct treatments over to the right, we have to think about is it infectious, et cetera, and we have to be treating that underlying cause along with trying to treat with our anticonvulsive agents. Clinically at our institution, I have not used inhaled anesthetics. I know others that have. I know it's very difficult to try to use the inhaled anesthetics in the ICU. And so I think that's the major limitation, although there are some reports out there that it has been effective. Hypothermia, tends to be used at, again, sort of an end stage if we can't get, it after we've tried everything else, again, to try to cool the brain off, as we say, slow it down, decrease the metabolic needs of the brain, and then in hopes of that helping. But it also, when you cool the patient for hypothermia, it also slows down the metabolism of all the medications we're giving the patient, which is going to prolong the effects of these agents that are liver metabolized, especially as we do the hypothermia. So you have to be cognizant of that and make sure. And there's no real good way to change the doses of those unless you're actually drawing levels of some of the agents. So things that are out there have shown some benefit. Everybody's using them at different time points if they're trying them. And you do have a lot of other things to think about as you're, in regards to the plus and minuses of using some of those. I think I've touched on most of those questions. If I missed one, I'm very sorry. But I think what I would, just as a wrap up, as to when we use our anesthetic agents and we're trying to take our patients off of these drugs, again, optimization of the anticonvulsants that you have on board for maintenance is key. Also, when you come down, another point was made earlier, that you have to come down slowly on these drips. It might take you several hours to get them off the drips as you're weaning them from the anesthetics, because you need to think about the half-life of the agents, and come down again, maybe every 4 hours, and see where you are and make sure the patient's not going back into status, and then go another 4 hours. And, you're cutting the dose maybe by 20–25% as you go down. So if you take it slow, just like we know when we take patients off multiple agents for seizures, right? The faster you go when you withdraw drugs, the least likely they are going to be able to keep them in, without seizures. So it's probably the same scenario with our status patients. Make sure you're going slow with the wean. Make sure you have adequate drugs on board with adequate doses of the anticonvulsants, so that you can effectively wean these patients off and keep them out of status.
That was great, Dr. Brophy. I think we had a wonderful discussion today. As you rightly said, we can even discuss for another 4 hours, but we don't have data on some of the things which we use regularly. Still, we need to generate more and more data to be precise on our treatment. Like you rightly said, from the beginning, the goal is to stop the seizures, and we employ strategy, the effective drugs at appropriate doses to stop the status as quickly as possible. And that is the key to the outcome. And today I would like to thank all the panelists, and a special thanks to Dr. Brophy for taking her time after a very long day and joining our program. Thank you so much, Dr. Brophy. It was a pleasure, absolute pleasure to have you here, and we'll be in touch with you. Thank you, Dr. Brophy.
All right. Thank you very much.
Thank you. Thank you, all the panelists. Thank you. Thank you, Dr. Prasanna. Thank you, Manish.
Thank you.
Thank you, Dheeraj. Thank you, Deepti. And thank you, Ajay. Yeah, thank you. Thank you all. And we have the ISNAC conference coming up. So after the conference, we'll catch up with Dr. Deepak Sharma on the missed topic, which was missed last week, the acute ischemic stroke management, anesthetic management of acute ischemic stroke. Till then, goodbye. See you all in Gurgaon, Delhi. Wish you all a happy day. Thank you.
Thank you.
Thank you.